How often does antibody buildup happen and people get resistant to treatment? And are there populations or maybe times in life when that's more likely to happen? Let's say if you're treating, pediatric patient and then they go through something like puberty, are there milestones that make that more likely to happen?
That's a good question. And then you're right, because they do grow and they change. So I also think about hormonal changes with women. It also takes a part of it, or people when they get comorbidities. But just being on something, your body itself becomes used to it and it won't respond the same way. I would think maybe 20-30%. It could be more, but that's what I've seen about in my own practice, where that's why I'm a little bit more hesitant to change people. And I want to make sure it really has not worked before I change them.
Mhm. And speaking of hormones, how do things like pregnancy, lactation, pediatrics, like I mentioned, severe palmoplantar or genital psoriasis change your ladder? What would you like community dermatologists and other prescribers to do differently, in your opinion, in these groups?
So, especially for pregnant or lactating mothers, that one's a little bit more apprehensive because you don't want to go against a gynae. And you should talk to somebody who is pregnant with their obstetrician to say, let's work together. She's already been on a medication. There is one that actually is has an indication in pregnancy, and that's Cimzia. It's a tumor necrosis factor biologic. But you should really work with that obstetrician before you do that. Pediatric indication, definitely. Humira has always been out for like rheumatoid arthritis. So that was one of the older ones that you can use in children. But Stelara, like I said, Taos can do the same. You want to make sure that they don't have like bowel syndromes and stuff like that. So there are some that you would never give somebody who has like a concomitant, like irritable bowel syndrome, like Cosentyx, because that's one thing that might make it worse. So you do have to look at their comorbidities.
hmm What is your standard monitoring plan, like labs visit, infection vigilance for a stable patient on methotrexate or a biologic? And where do you think clinicians commonly over or under monitor?
So, I'm from the age where some biologics were taken off the market, and it is very disheartening to sit there and go, I just gave somebody this. So for biologics, in the beginning, I just give them every 6 months, especially the ones they take, and I want to monitor you. I need to see what's going on. And actually, more insurance companies are saying, when's the last time you've seen your patient that you want all of a sudden for us to refill this drug with? So every 6 months, I don't think it's overboard. In the beginning, I would do it more often, and I don't think I really needed that.
hmm
Um, for methotrexate, definitely I wouldn't go past two. It's 2 to 3 months, and usually it's two because that has carries more immediate side effects, and you want to make sure you don't miss an immediate cough or a drop in WBC. So you definitely want to see them a little bit more often. And that one isn't more long term to me for psoriasis, though I have some people who have stayed on it longer. It's not the usual long term drug.